Welcome to the show. I'm your host, Dr. Ronald Yap. Today, we'll be doing part 2 of our prostate cancer episode. Ami Kilchevsky, a esteemed colleague from Concord Urology, joins me again for this episode. So welcome back, Dr. Kilchevsky.
Thank you for having me.
And we'll pick it up where we left off. Part 1, please take a look at that if you haven't had a chance to see it. We went over the diagnosis of prostate cancer and screening, staging, and now we'll talk about what do you do next when you have that discussion with the patient about what to do next. So Dr. Kilchevsky, so we discussed the pathology, the screening. So a lot of stuff out there in the media about you have it, but you don't need to get treated for it. Something else is going to get you first. All that could certainly be true. Talked about low and higher risk diseases. When you're sitting down with that patient, active surveillance versus watchful waiting, in a quick nutshell, we talked a little bit about it part 1. Who do you offer to what? And tell me about, what your pathways are for each type.
Excellent question. So there is first and foremost, a difference between active surveillance and watchful waiting. Active surveillance implies that we will be active in terms of surveilling the prostate cancer, which could mean serial biopsies in the future, whereas watchful waiting is more of a wait-and-see approach, which usually entails men who don't have the same longevity that men who are put on active surveillance have, and it's more if the prostate cancer becomes symptomatic or if certain numbers become very elevated, then certainly something we can address at that time, but not with the serial biopsies. A man who would be a candidate for either active surveillance or watchful waiting is a man with a low-risk prostate cancer. As you may recall from part 1 of our talk, that low-risk prostate cancer would be defined as a Gleason score of 6 or less. That being said, we are progressing to put men on active surveillance with a small amount of Gleason 7, which is actually an intermediate-risk prostate cancer. It's not necessarily standard of care, but it is certainly something that we are moving to, especially in the age of MRIs for evaluating any sort of additional lesions in the prostate. So a man with a Gleason 6, a low volume of Gleason 6, or a man with a very low volume of Gleason 7 disease who may be a candidate for active surveillance is someone that I would recommend getting repeat PSA, that's the prostate-specific antigen that could be elevated in prostate cancer, every 6 months. So when a man comes to see me with a new diagnosis of a low volume Gleason 6 or a very low volume of Gleason 7 disease, I would talk to them about active surveillance and follow up that conversation if they're comfortable with a PSA in 6 months. And after that PSA in 6 months, if that PSA is stable, then I would have them come back to see me 6 months after that for a repeat PSA and a rectal exam. Essentially, no matter what the PSA and rectal exam show at that time, that patient is going to be counseled to undergo a repeat prostate biopsy. In most active surveillance protocols, men do require an additional prostate biopsy about 1 year after their diagnosis. We are now at Concord Urology moving to the point where we might be getting MRIs prior to a follow-up biopsy, but certainly that is not a substitute for proceeding with a transrectal ultrasound with prostate biopsy. So initially they get diagnosed with prostate cancer. They follow up in 6 months just to make sure they're doing okay. And assuming that they're doing okay with a stable PSA, then I would see them back 6 months after that for a repeat PSA digital rectal exam, which is a prostate exam, and a biopsy shortly thereafter.
And for watchful waiting, it sounds like you're really just trying to alleviate significant events from occurring, pain and suffering type things.
Sure.
Probably your older guy,
right.
Limited longevity.
So one of the knocks historically against urologists and widespread rampant PSA testing is that what do we do with a guy that might be 85 or 90 years old and comes to us because someone checked a prostate-specific antigen on him? We're kind of in a bind. And we know that if we biopsy enough 75 or 80-year-old men, we're going to find prostate cancer in a majority of those men. Not all of those men will go on to die of prostate cancer. In fact, a majority probably will pass from cardiac disease or issues related to blood pressure or diabetes, and not from the prostate cancer. So our goal as urologists is to make sure that the prostate cancer stays at bay and doesn't cause any major harm to the patient. However, should that prostate cancer cause harm to the patient in form of pain from metastatic disease to the bone or obstruction of their urinary system, then we would recommend treatment, either symptomatic treatment or treatment to get the underlying prostate cancer in check.
Mm-hmm. And there are options for those people too. It's not that we leave them and, oh, your number is really, really high, see you later. We have hormone treatments, androgen deprivation therapy to limit spread of disease. You won't cure it, but you'll try to slow it down, or even radiation-based treatments to bony spots where you can really get a lot of alleviation of pain and suffering, even in those watchful waiting patients. So,
absolutely. And even in that situation, as you point out, there's not a lot of necessarily invasive procedures, but rather there are a wide number of things that are becoming more available, including vaccine therapies for metastatic prostate cancer, which I think is the future of a lot of different types of cancers. But what we're able to do is actually find a sort of virus that we attach to PSA, and when we enter it into the body, much like a flu vaccine, it will actually help the prostate, help the body fight prostate cancer. So what we're doing is actually using the body's own immune system to fight the prostate cancer. And I think that's one of the projects that I was working on down in Bethesda, and certainly something that I think within the next couple of years will be very widespread. Patients did very well with vaccines for prostate cancer. One vaccine in particular called Prostate is now more commonly used. There's Provenge or Sipuleucel-T, which is another type of vaccine for metastatic prostate cancer. So men are living longer even with metastatic prostate cancer.
Those are good points, and I think you're speaking about a lot of the modern thoughts where you're going moonshot, man. You went moonshot on me, you went precision medicine, man. So yeah, sweet. So let's jump next to surgical management. So we're not doing observational strategies such as active surveillance or watchful waiting. We're talking about that index patient that we talk about, the most common type of person. Let's say he's 65 years old. He has some Gleason 6 or 7, which is some intermediate disease, clinically organ confined, interested in having surgery. So tell me about what you tell that guy, some of the risk pitfalls they could have, and tell me a bit about how you do it.
Sure. So assuming that the gentleman that I'm seeing has a intermediate or high risk disease or a very high volume of a Gleason 6, which is a low risk disease, they may be a candidate for surgical intervention. Now, we take surgery very seriously. The patient has to be in good shape. Their heart has to be able to handle the surgery because it is a big abdominal surgery. What we have progressed to over the past decade or so is robotic surgery. So I always tell patients, and I'm sure we'll talk about this, I'm interested to hear your opinion, but I always tell patients that you have to ask the surgeon what they're comfortable with. And my preference is robotic surgery to remove the prostate. We make a series of 6 incisions in the belly. The biggest incision is over the belly button, which is where we actually extract the prostate from. Each incision is about 1 centimeter. The biggest one, again, is over the belly button, which could be about 5 to 6 centimeters, depending on the size of the prostate. Surgery itself could take anywhere from 3 to 6 hours, depending on how large the prostate is, whether we do a node dissection, whether we save the nerves. The recovery in the hospital is relatively quick. So patients now are leaving the hospital almost universally the next day after a robotic prostatectomy. They often will only go home with a catheter. Sometimes men do go home with a drain in their abdomen as well, but in general it's just a catheter. The catheter stays in for approximately a week. It's there to allow the healing around the bladder to occur, and when they see me back in the office a week later, we'll take out the catheter and have the patient urinate on their own. The recovery itself with robotic surgery tends to be quicker. The cancer control outcomes between robotic and open approaches are very similar. However, in my experience, patients tend to leave the hospital at least 1 day sooner and have a little bit less blood loss with a robotic approach. But again, it's really up to the surgeon's preference. If a surgeon has done 500 or 1,000 open prostatectomies and that's what they feel comfortable with, then I think that's a reasonable approach. The benefit of the robotic surgery is a quicker healing time. So in general, I tell my patients that they can expect to be back at work, depending on what they do, anywhere from 3 to 4 weeks after a robotic prostatectomy. They're probably not going to be feeling like themselves for at least 3 to 4 months after surgery. It's still a long recovery. Unfortunately, I tell my patients that with small incisions that often are covered with shirt or with a patient's own belly hair, that a lot of other people won't even realize that they've had surgery, so they lose some of the sympathy points. But certainly they can recover in a relatively expeditious fashion. But I mean, what's your experience in terms of open prostatectomy? I know you've done many open prostatectomies.
Sure, and I think this is where you get this new school, old school type argument. And I have to tell you, if you go out and talk to the urologic community, I mean, there are even people that can get up into fisticuffs about this whole thing. Which is better, open, robotic? In the hands of a master surgeon that's done, open versus a novice surgeon that's done, robotic. Which would you have? Well, I guess like you're mentioning. I mean, this is a tool. I always tell patients that it's all about your rapport with your surgeon. Who do you trust? How many have they done? Because coming out of Northwestern and working with Dr. Catalona, he did damn good radical prostatectomy, open. They did great. They didn't go home with opioids. That's a guy that's done over 5, if not 6, 7,000 by now. In his hands, fantastic. But I would say if you were to ask me in 2017, where is it at? I don't think anyone's going to get around the fact that with the robotic approach, the blood loss is less. Mm-hmm. You have magnified views. And like we talked about, in the hands of the right kind of guy that the patient gets along with, I really do think it is moving towards that robotic approach. But like I said, according to our national guidelines, just talk it out with your surgeon. They're both valid. They're both standard of care. It just depends on your relationship with the guy that you're doing it. Because it doesn't matter whether it's the robot or not. If you got a bad vibe about that surgeon, you go somewhere else until you got that, got to be lockstep with each other, because it's got some potential long-term effects, and you're bonded to that surgeon for the rest of your life, actually.
Absolutely.
So, and on that note, I guess we talked about the pathway, and we'll talk about the discrete, and I don't think you can distinguish it between robotic open, about the side effects that we'll talk about in a second, but I don't think these aren't unique to just surgery, mm-hmm. And we'll kind of focus it on surgery, but radiation procedures have similar type complications. So give us a summary of what those pitfalls could be.
Absolutely. So I think you bring up a good point, which is when we're counseling patients about treatment options for prostate cancer, while there are better options for their cancer control, all the options come with side effects, and it's unfortunate because we want to ideally find the solution that offers the fewest side effects possible, but essentially any time we intervene on the body, there's going to be a repercussion, be it with medications causing side effects, surgery causing side effects, or radiation causing side effects. Dr. Sheldon spoke about side effects related to radiation, which can be similar to surgery, but speaking specifically to surgical side effects, the first and second most commonly talked about side effects from robotic prostatectomy are urinary incontinence and erectile dysfunction. Now, in my experience with robotic surgery, you're better able to identify the nerves on either side of the prostate, which allows the surgeon in the right patient to be able to peel the nerves which kind of run alongside the prostate away from the prostate, and thereby better allow the patient to have preserved erectile function. Now, simply doing a nerve-sparing procedure does not by any means guarantee that a patient will have erectile function postoperatively. I tell all of my patients that the erections inevitably will get worse after surgery. Mm-hmm. My goal is to preserve some degree of erectile function. The other issue is with ejaculation. There will be no ejaculate. A patient may still have the experience of an orgasm, but there will be a dry orgasm, so nothing that gets emitted. Assuming that the patient can get erections postoperatively, oftentimes they still may need an additional medication, such as you might have heard of a Viagra, which is a type of medication that allows blood flow to be increased to the penis. The other major side effect to the surgery is urinary incontinence. Nearly all patients, when the catheter comes out 1 week after surgery, have some degree of incontinence. I tell all my patients that incontinence isn't aimed to be improved within the first week or two. My goal is that within about 1 year that they are happy with their level of dryness. Inevitably, when the catheter comes out, the patient is going to need some sort of pad in their boxers to help absorb some of the leakage of urine. With time and with exercises that can help control the pelvic floor muscles, the goal is that those patients will develop dryness that they're happy with, that they can go to work and not worry about leaking. One really incredible thing that we have here in Concord is a physical therapy team that works very closely with all of our patients after surgery to help do exercises such as Kegel exercises that strengthen the pelvic floor muscles and allow patients to get continence at a much earlier rate than I've seen in other places. So I think with a very careful surgical approach, you can not only save the nerves in the right patient, but also preserve urinary continence so that several months after surgery, the patient can play a game of basketball or go to the grocery store and lift up a bag of groceries without having to worry about leaking urine.
And it's definitely a process.
Absolutely.
And I like to shout out to pelvic medicine, where we have a physical therapist in our practice via the hospital that can work with those muscles and teach you how to bulk those up, which are those pelvic floor muscles, to help with urinary control. And also, we have Maggie Hammond in our practice, who's our oncology nurse navigator, so we got to give her a shout out too, where she helps coordinate the perioperative care, meaning before, during, and after.
Yep,
Any
absolutely.
concerns, relay them to you and Dr. Santos and our group. I'm helping with some of these questions.
Which is, it's also a very, having practice at other cancer hospitals, across the country, I will say that that is a very unique part of our practice at Concord Urology, which I think puts the patients at ease, because if they have a question about appointment times, or for example, there's a snowstorm and they can't make it to a certain appointment, that there's a resource that's readily available. You and I might be in the operating room, but Maggie is around to be able to answer these questions, and our staff is always around to be able to answer these questions.
Yeah, it's a really, it's definitely a process, and it's a personal touch. So after the surgery, they take out the catheter. What's the follow-up care? When do you check in with these patients? And
so at the 1 week follow-up, what I'll do is I'll review the pathology. One thing that we do know about when we remove the prostate is that there's about a 25% chance of finding a higher grade pathology on the actual final specimen. And the reason for this goes back to what we were discussing in part 1 of this episode, which is that we essentially right now are doing blind biopsies. The transrectal ultrasound is a great tool, is a great screening tool for prostate cancer. However, it doesn't always find the index lesion, the biggest or most aggressive lesion. So sometimes when we take out the prostate, we'll actually find that the patient harbors a higher grade cancer than what we had thought. So what I always talk to my patients about is node status. So I almost always do a node dissection because prostate cancer can go to the pelvic lymph nodes. So I spend a little extra time making sure that I remove all the lymph nodes in the as many lymph nodes in the pelvis as I can. And I talk to them about the node status. I'll talk to them about the margin status. It's very important to have negative margins when you remove the prostate. There's also some concerning features to prostate cancer. Sometimes the prostate cancer can have started to escape from the prostate. That's called extracapsular extension, and that's something that can portend a worse prognosis for the patient long term. Sometimes patients, if they have positive margins, or if they have very concerning findings on their pathology, I might even recommend a consultation with Dr. Sheldon or someone else in radiation oncology to go over the potential of needing additional therapy even after prostatectomy. That's what I do in my 1 week follow-up. We then also have Susan Buckley, who's our nurse practitioner in the oncology branch, who will see patients usually at about 2 weeks just to make sure that they're doing well, that their incisions are healed, and the incisions should be healed at that point, to go over some of the overall, again, pathology, if they have any additional questions about it, if they have additional questions about their incontinence or impotence at that point. She'll arrange for them to start going to physical therapy at that point. I've gotten in the habit of giving patients medications like Viagra at that point because I think that penile rehabilitation, while never really borne out in studies, is actually helpful. And I've noticed that patients who are started on it at an earlier point are more likely to develop erections. So again, the data is less clear about that. And then really the biggest follow-up, in my opinion, is that 6 week follow-up, because at 6 weeks, I see the patient back, and I want to not only make sure that they're doing well clinically, but also I'll have them get the PSA test before seeing me, and ideally, if the margins are negative and there is no concerning findings on the final pathology, I would want to see that PSA be 0 or undetectable, which is less than 0.04 oftentimes.
And that's a great distinction. So when you take out the whole gland, there should be no PSA. And when you have radiation treatments, it will go down, but you occasionally could get very low prostatectomy level PSAs, but you're looking for a decline and having it steady. With prostate removals via robotic or open approaches, it's got to be low, essentially undetectable. And as you screen them, so let's say everything's undetectable at that 6 month checkpoint, what's your follow-up strategy after that?
So again, depending on the pathology, if it is simply an intermediate risk prostate cancer, for example, a Gleason 7 prostate cancer, I think that it's safe to check PSAs every 6 months or so for the first year. And ultimately, my goal with these men is to go to annual screening. So to check a PSA annually. I don't see any reason to do a digital rectal exam at their annual follow-ups unless there's a recurrence of their PSA. One very important thing to bring up is even though we could do a great job in terms of minimizing the risk of developing a recurrence of prostate cancer, I tell all men, regardless of whether or not they have a low-grade prostate cancer or a high-grade prostate cancer, that they are entering a lifelong follow-up. So in other words, I never just dismiss a patient from my practice and say, you don't need to follow up. All these men are always at a risk of recurrence. Now, some men are at a very low risk of recurrence, maybe less than a 2% chance of recurrence. But there are men who have intermediate or high-risk cancers that are a much higher chance of recurrence. I think one of the downsides to less frequent and less rigorous PSA screening, which is often the case nowadays, is that we're finding and diagnosing higher grade prostate cancers in younger men. Now, we are able to do prostatectomy prior to radiation, but it's important to keep in mind that doing surgery after radiation is a very challenging feature. After radiation, men have a lot of very firm tissue planes that make a smooth surgical dissection not impossible, but certainly quite challenging, and the side effects from that surgery go up. So in men that are young, that might have a high-grade prostate cancer, I am now seeing more of those men in my practice. I'm offering those men surgery up front with extended lymph node dissections, knowing that a majority of those men will eventually need to go on to get radiation, but I might buy them a 5 or 10 year radiation-free interval followed by radiation, which they can tolerate when they might be in their mid-60s, and then have a good survival rate after that.
And that's the whole concept of the multimodal approach that you were discussing, where at times, given patient pathology, what the margin status is, you may have to stack these treatments. And one thing I picked up from your discussion is that it's also individualized, meaning that there's so many PSA levels that they start off with, and digital rectal exams and pathology, that it wouldn't necessarily be cookie cutter for everybody, that it will be variable depending on what those characteristics are as far as PSA follow-up. Do you need adjuvant therapy? And also in that initial discussion, some people just don't want to go the surgery thing. They're just not feeling it. They're just not going there. That's cool. Radiation has its own pluses and minuses. But there's some people that just, on the other end, they just can't stand the idea of leaving that gland in.
Absolutely.
And that speaks towards doing the surgical approach. You gave a great overview of what it is. People spend years studying this. You've done research on this, and I tell you, we could spend every day just talking about prostate cancer. So I really enjoyed the discussion.
Yeah, thank you.
Any closing thoughts?
I think at the end of the day, it's important that you have an open and frank discussion with the patients and the patients with the physicians, because this is a very individualized approach. And I think we cannot look at this as a cookie cutter, if A, then B. I think every patient is unique. Every patient has their own backstory. We need to get to know the patient. We need to know where they're coming from. And I think if we do that, not only can we provide the appropriate medical care, but also just from a patient comfort perspective, that they feel good with the treatment plan that we've put in place. Because if the patient does not feel good with their decision to move forward, then any outcome is going to be problematic. They want to feel comfortable. We want them to feel comfortable, and it's very important that if it takes 3 meetings with the urologist or 5 meetings with the urologist, and that's what we do to make them feel comfortable.
I hope you're enjoying hanging with us here,
Yeah.
and thanks for coming on the show.
Absolutely. Thanks for having me.